Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Great. Good to see everybody, and thanks for having me again. So this will be a little bit of a hybrid here. I'm going to do mostly syphilis, and then Christine Johnston's going to do part 2 next week. But since there's so much material, we kind of agreed that I would do BV and Trichomonas as well, so I'll briefly do those at the end of the syphilis. So no conflicts of interest. So as you know, the 2021 CDC, now STI, not STD, treatment guidelines were released in July, and this was based on many discussions that happened over a number of days in Atlanta in June of 2019, where they really looked at all of the new data evidence studies that were put out since the last iteration of guidelines, and they gave us a new set of recommendations for syphilis, including some enhanced discussion about algorithms, ocular syphilis, and then something we had all been kind of looking forward to as clinicians, a little more guidance about when we need to be doing lumbar punctures, and then also some expanded risk factors for testing in pregnant people. So I'll talk about those primarily, and then, as I mentioned, we'll do some updates briefly on BV and Trichomonas. So just to start us out, again, I think this is not new information for anyone, but the new guidelines really make a distinction and highlight specifically the algorithms. And so just to remind everyone, the traditional and the reverse sequence algorithms are a little bit different. The traditional, you start with a non-treponemal test of your choice, so RPR or VDRL, and you go down the tree here as you see. So if it's positive, you do a specific treponemal test, and that could be an IgG, CIA, lots of different types. In this case, it's a TPPA. And if that's positive, you have to figure out whether there's a past or present infection. For the reverse sequence algorithm, what you're doing is sort of starting with the treponemal test first, so something more specific. If that's positive, then you do an RPR to figure out if this is a new or past infection. And if that's negative, you're doing a tiebreaker with a second treponemal test different from the first one you started with. So for people who do an EIA first, maybe you're going to do a TPPA second. And again, based on what your result is there, you have to figure out, based on the clinical history and your treatment history, where you are in terms of past or present infection. So what the guidelines remind us for the traditional algorithm is that really it's important that we use the same non-treponemal test every time. So if you're going to do an RPR for someone, ideally you would do that for follow-up and at the same lab if possible, because you can have variation between tests and between labs, as I'm sure you've all experienced. And then also remembering that if you are going to switch back and forth, that's not recommended because the VDRL actually can give you titers that are lower than RPR, so they're not quite apples to apples. You want to stick with the same test. There is a little bit of information that they put. I encourage you to read the guidelines if you were interested, where there's a little bit of nuance in the term serofastness that we use. There's actually 2 sort of buckets you could be in. One is where someone has an inadequate serologic response after treatment, and so that might be more consistent with someone who is at risk for treatment failure versus someone who just doesn't revert their serologic test to negative after treatment. So a little bit of a nuance, but they sort of highlight that distinction in the guidelines. And then when we talk about the reverse sequence algorithm, one thing that I always like to remind myself of is, we tend to say classically that the treponemal tests stay positive for life, and I think that is most often the case. But if someone was caught very early and they were treated during the primary syphilis stage, within the first week or 10 days, it is possible up to a quarter of people can actually revert their treponemal test back to negative. So just to keep that in mind, that doesn't always mean that they've never had syphilis if their test is negative. So it's good to have treatment history. And then the guidelines also talk a little bit about the fact that if you are going to be using a treponemal test for that sort of tiebreaker step that I showed in the reverse algorithm, making sure it's a test with a different target. So I think most labs do that already. You won't have to worry about it, but just a reminder. And there is a little bit of information about, as more studies are coming out, that the EIAs and CIAs that we get, so when you send off for a syphilis IgG, there is actually a quantitative value that is associated with that. We don't really use it in the United States, but there is growing evidence to show that could predict whether or not someone has a positive TPPA. So maybe in 5 to 10 years in the United States, we may not need that second step. If somebody has a very positive EIA, we could just kind of stop there, but not yet. That's coming in the future. Okay, so shifting gears to neurosyphilis, ocular syphilis, and otosyphilis. So some updates here that are important for all of us who are seeing patients clinically. So just as a reminder, for ocular syphilis, this can occur at any stage. Most often we see it in the early stages of syphilis. We can see panuveitis, really any area of the eye can be affected, retinal vasculitis, cranial nerve dysfunctions, etc. It may or may not involve the CNS, and so I think that's where this new piece comes in with this set of guidelines, where they say if a person has isolated ocular symptoms, so whatever that is, new floaters or flashers or eye pain, and an ophthalmologist sees them and confirms they have an abnormal exam, so they're diagnosed with anterior uveitis, let's say, and they have a reactive serology, in that case, you do not need to get an LP for CSF analysis before going forward with treatment. So I think that's different because we always were on the fence about, if somebody had eye symptoms, should we be getting an LP or not? And this is sort of definitive in saying, if you have evidence on exam and by serology and the person has symptoms, that you don't necessarily need to get an LP. So I think that's liberating a little bit. The caveat for that is, if you don't have an abnormal exam, if you can't get them to see ophtho in time, or they do their exam and it's normal, then CSF may be helpful. So just think, if you need additional pieces for diagnostics, then you may consider doing an LP at that point. For otosyphilis, another way that they're kind of helping us to maybe limit the number of LPs that we're doing, if somebody has isolated auditory abnormalities and they also have a reactive serology, we really don't necessarily need to be getting an LP at all, because evidence shows that people in these cases almost always have a normal CSF profile, and we're not adding anything to our diagnostic data by getting an LP. So I think for otosyphilis, if you have somebody with reactive serologies and abnormal symptoms, you can go forward and treat. You don't necessarily need to get CSF analysis. And this is just sort of a reminder here on the right side about our diagnostics for CSF. A lot of questions that we get about this from clinicians, because it can be confusing and it's hard to remember. The VDRL, remember, is very specific for syphilis. So if you have a positive result, that's helpful. But if you have a negative result, that's not necessarily helpful. It does not rule out neurosyphilis because the sensitivity is pretty low, anywhere from 25 to 30%, depending on who you talk to. In contrast, the FTA ABS is actually more sensitive. And so if you have a negative result, it's very, very unlikely that you have neurosyphilis. But again, the specificity is not great, 55 to 60%. And then for people who do get a TPPA from the CSF, that's not done as often, but the sensitivity and specificity are similar to the FTA ABS. So I kind of think of those last two as similar tests. So if you're going to be getting 2 and not 3, I would probably do the VDRL and the FTA ABS. Those are probably the most common if you're going to use 2 tests to help you decide. Okay, and then the last thing about neurosyphilis. So again, growing evidence from many more studies that have come out that people who are immunocompetent or people living with HIV who are on ART, effective ART, and there's no real distinction about whether or not there's viral suppression. So that I found that interesting, but it just says effective ART, that if they have a normalized serum, RPR, or VDRL, that actually predicts having normalized CSF parameters after someone's treated for neurosyphilis. So what I take that to mean is that we don't necessarily need to be getting repeat LPs for CSF exams for people if they've had a good serologic and clinical response. So the studies that led to this recommendation, what they defined as a serologic response was having a fourfold decrease or reversion to non-reactive of that RPR, or if somebody has a really robust response, like their RPR drops greater than 8-fold, that would also qualify. So again, we don't need to redo an LP at the end, which is helpful because I think many of us are not able to do that anyway, and the patients don't want to because it's a hassle. So if they've clinically responded and you've had good serum response, then we can forego that. Okay. Any questions about neurosyphilis before we move on to pregnancy? Okay, so syphilis and pregnancy, the main new thing that the guidelines say is that there is a permittance to up to 9 days between doses, which I think I had always said, if a person who's pregnant misses a dose after day 7, that we should start the whole course over again. But I think most people think that it's better to get in, a course if you miss a day or two rather than not. And if we're telling someone they have to restart after they've already had 2 doses and that drives them away and they never come back, that's not good either. So optimal dosing, the timing is always 7 days, of course, if you're treating someone for latent syphilis. But you can have a window up to additional 2 more days. But beyond that, I would still say don't. You need to retreat them, restart the course. So don't offer that additional dose after, the 10th day. And then they do talk about some specified risk factors for people in pregnancy. And this is not new to any of us, I think. These are all things that are associated with syphilis acquisition. So when you see these, we should be thinking that we want to test early and often. So people who have sex with multiple partners, if they're engaging in transactional sex or use drugs during sex, if they've come into prenatal care late, so their first visit was any time in the second trimester or later, if they haven't had any prenatal care at all, if they're using meth or heroin, if they've been incarcerated or their partner is, and then if they're living unstably housed or they're homeless. And then, of course, anytime that you see a person who's pregnant, you want to evaluate for risk factors and treat sex partners. That's always important. So the other thing that is new, and we get a lot of questions about this at our county clinic, is trying to interpret what these serologies mean for someone who's pregnant. And so what I think is nice about these guidelines is they actually have a paragraph for sort of each combination of serologies you might get. So I put these into kind of a management tree to make it a little easier. So if someone has an EIA that's positive, an RPR that's negative, and a TPPA that's positive, you're kind of going down 2 branch points. So you're trying to figure out if they've had an adequately treated infection, and that's based on history, getting public health to help you, what have you. If that's the case, they don't need any further workup. But if you cannot confirm that they've had a history of treatment, makes sense, you should stage the infection and treat accordingly. What's a little more complicated is if someone has an EIA that's positive, the RPR is negative, and then the TPPA is negative. The question is that a false positive? And we hear this all the time. So what the guidelines say is you should be asking these questions. Does the person have a history of prior syphilis? That might mean this is likely to be a new infection, maybe. Do they have an abnormal exam? So evidence of syphilis clinically. Is the person living in a high prevalence community, which I think many of ours are? And do they have a partner with syphilis? So if any of those is the case, that's putting you down the pathway into this is likely to be a true positive EIA. Or if the person's unable to follow up, then you're kind of in that same bucket. So the way that you would think about it is based on your clinical exam, if they have primary syphilis, if you see a chancre on your pelvic exam, of course, treat for primary syphilis. If they have a normal exam, you're kind of in 2 buckets here. So if you can't confirm the history, of course, just treat because you don't want to risk loss to follow up. Or if the exam is normal, you could do the strategy where you repeat testing at 4 weeks and then wait to see what that shows. So if the RPR and the TPPA are positive at that point, then you would be treating. So a little complicated, but I think kind of helps to compartmentalize it a little bit. You have some options when it comes to people that have risk factors for syphilis. If all of these are negative, which is not often the case, but if that is the case and they are able to follow up, they've proven that they come back to visits and you have a good way to contact them, you could do the strategy where you just repeat testing, and then if it's negative, you stop. Then we call that a false positive EIA. Hopefully that'd make it more confusing, but it's written out in text if you would like to read it that way, if that's better for you to understand. Okay, before we finish with syphilis, as I was reading through the guidelines, just kind of pulled some pearls that I think is always good to remember, and some things that are sort of new in this iteration. So knowing that primary syphilis can cause multiple atypical or painful lesions, so it's not always a single painless chancre. So I think that's classically what we're taught, but just remembering that that's not always the case. The fact that we do treat latent stage syphilis longer because we think that the bacterium actually hides out in sequestered sites and is dividing more slowly. So that's the reason why we need the 3 weeks of penicillin. I get this question sometimes about whether or not steroids are helpful for somebody who may have, a vestibular abnormality or sensorineural hearing loss for otosyphilis. And there's not really any evidence that that's the case, although it is done, I think, in communities sometimes. Also, another question about when or not you should give benzathine penicillin after someone finishes neurosyphilis treatment. So the guidelines say it's okay to consider doing, but they don't say yes or no. So I think most people do a treatment course that would be similar to a full late latent treatment course. So if somebody's getting 10 days for neurosyphilis, you might give an extra shot of bicillin at the end of that so that they kind of get to their full treatment course for late latent. But it depends on the provider, really. No evidence that antipyretics will prevent Herxheimer reaction, but you can use it to treat. And then for syphilis in pregnancy, if it's diagnosed and treated before 24 weeks, the soonest that you should be repeating titers is 8 weeks after treatment. Don't do it before that because it's not going to be helpful and could actually be confusing. If the person is diagnosed and treated after 24 weeks, then the soonest you would repeat titers is at delivery. And then for serofast people who do not have HIV, there was a new study that was released earlier this year from China where they retreated all of these people who were serofast for years, in some cases multiple times, and it did not meaningfully change serology. So I know that it may make us feel better to do that, but really there's no clinical difference in retreating people if they are serofast and they've had an initial response. Okay, so that's all of syphilis. So moving on, shifting gears a little bit to BV. So a few different additions to recommended therapy are kind of the primary updates, and that is in the form of Metrogel being added as a primary recommendation for therapy, giving a 5-gram intravaginal application daily for 5 days. And then also an equal recommendation would be clindamycin cream, 2%, giving 5 grams at bedtime for 7 days. You can also, of course, still do the standard metronidazole 500 milligrams twice a day for 7 days. And talking about metronidazole, sort of debunking a kind of classically taught myth, what has been removed from the guidelines is the disulfiram-like reaction. So we do not need to counsel patients that they should avoid alcohol when they're taking metronidazole. I think that was based on some very old sort of anecdotal data from the mid-20th century that has not really been borne out in rigorous studies. So don't need to worry about that anymore. And then in terms of alternative therapies, there are 4 prior regimens that were there, and those all stayed the same. But what has been added is now you can use secnidazole, which I have not been able to get, and I think is sort of expensive. But if that's the option that you have, you're giving 2 grams of oral granules in a single dose. And we always recommend that they sprinkle that on something soft like applesauce or pudding or yogurt to help them get it down. And then drinking a full glass of water after swallowing will help with the absorption. Otherwise, everything else is essentially the same for the BV guidelines. It was just some updates on treatment. And then some big changes to Trichomonas. So specifically for treatment for women, after we had new evidence come out about there being increased efficacy for treatment in women when we're treating with metronidazole for 7 days rather than giving a single dose of metronidazole. So here on the left, I kind of put what used to be the 2015 guidelines, which is that we could give 2 grams of metronidazole times 1 or tinidazole times 1 for women that were HIV negative. And I think for men, it didn't really specify, but that's what we did. But now what we are doing for all women is giving metronidazole 500 milligrams twice a day for 7 days. And then as an alternative, if they can't tolerate that or for whatever reason you can't get it, you can do tinidazole 2 grams times 1. For men, we are still sticking with the single dose because there's no evidence for extended treatment regimens in men. So 2 grams of metronidazole times 1 is still what we do. And then I find it helpful that they gave us some guidance on what to do if someone has a persistent infection. So, of course, you're going to bring them back in, ask them about their symptoms, trying to assess if they've had exposure for reinfection. So for women, if you think they were re-exposed, then you would treat them with the same regimen you used the first time. So 7 days of metronidazole twice a day again. If you are certain that they haven't been re-exposed and you think this is a persistent infection, then you move to giving higher dose metronidazole. So that's 2 grams daily for 7 days, or tinidazole 2 grams daily for 7 days. For men, same sort of scenario, figure out if they've been re-exposed or not. If they have, you would repeat the same regimen. If not, then we don't do the higher dose, but a lower dose for 7 days. So metronidazole 500 milligrams twice a day for 7 days. And there are some additional recommendations I didn't include here that give you alternatives for people who have either persistent or recurrent infections, because that happens sometimes. Really, nitroimidazoles are the best therapy that we have for trichomonas, but there are some alternatives that the CDC outlines. And then at that point, you're really looking to send specimens off for resistance testing, you can always call the CDC for help at that point. Okay, that is everything.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.